Thanks, Sanjay.
Good afternoon. Welcome to the third session of the
Good afternoon, ma'am.
foundation course in palliative nursing. So the topic for today's session is the management of pain, and we have the faculty, Dr. Greeshma ma'am, and also facilitator, Dr. Shiba ma'am. So for further facilitation and taking up the session, I kindly request Shiba ma'am to take up the session.
Okay, thank you. Very good afternoon to all. So this is our third session. We are going to learn about the management of pain. Today, last week we learned about the assessment of pain, the types of pain and all. So now you know how to, when a patient comes to you with pain, how to do the assessment, what are ways to do the assessment. You all know that. Now, management part, we are going to learn management part. Today we have an eminent faculty with us, Dr. Greeshma Nair. So she is a palliative care physician. She did her certificate course in pain and palliative medicine from Pallium, India. She has 4 years of experience in palliative care. So she is one of the well-versed person in this field. Ma'am, welcome and over to you.
Thank you, Sister Sheila. And good afternoon, everyone. So today we are going to learn how to manage pain. Okay. Next. Yeah. So this is the second session on pain management, right? So you already studied, you already got the class on pain assessment. So I'm not going to detail how to assess pain and all. Here we will be discussing the topics like basics of WHO analgesic ladder, step 1 and step 2 drugs, adjuvant drugs. Okay, next. Next. Okay. So what do everyone know what is a WHO analgesic ladder? Do anyone know?
Please answer.
Okay. No, okay. So for the first time you are hearing about this WHO analgesic ladder, right? So we will be learning about this ladder today in detail. So I will just show you what is analgesic ladder, then we will come to the features. Next, next, next. Yeah, this is the WHO analgesic ladder. Okay. So according to you, now you know how to assess the pain, and based on the severity, we used to classify the pain. We used to score the pain as mild, moderate, or severe. Or in numerical rating scale, we used to score it from 0 to 10 and all, right? So according to the severity of pain, the management also differs. So this is how it goes. For mild pain, we have some drugs. For moderate, mild to moderate pain, we choose a set of drugs, and for severe pain, it will be another. So this is the analgesic ladder. We will be seeing this in detail today. We can go to the first. Okay. So this WHO analgesic ladder, before this WHO analgesic ladder, it was there was no stepwise approach to treat cancer pain. Okay. So, and there was a very confusion around the management of pain, And we all know still um, now when we are prescribing opioids for severe pain, the patients and bystanders used to ask us, okay, about the usage of morphine and all. So the stigma is still present now, even now. So we can even imagine how it will be or how it would be before. Okay, about before this arrival of this WHO analgesic ladder. So after this WHO analgesic ladder, uh, the stigma associated with prescribing and taking opioids has reduced, and we now got a stepwise approach for pain management, and it is very simple, and we all can easily understand, and the confusion also reduces. You after this session you all will be able to know, okay, very clearly how to manage pain in different cases, okay, according to the severity. And prior to this WHO analgesic ladder, uh, there were many stigmas associated with using of opioids, and even medical practitioners were not able to understand and were not able to prescribe the medicine properly also. So they were dying, the patients were suffering due to cancer pain. But now, once we study this WHO analgesic ladder, there will not be any confusion for managing the cancer pain. Okay, next. Okay, the assessment of pain, you all know. First thing we have to understand is whether the pain is nociceptic or neuropathic, because it differs. The management differs in both these cases, and the intensity also we should know. Then only we can we can choose the management correctly. So we should know the intensity also. The visual analog scale and numerical rating scale is the most common scale that we use to assess the score. And type of pain also, you know, nociceptic and neuropathic pain. Nociceptic, there is somatic and visceral. Somatic is mostly associated with pain in joints, bones, connective tissues, muscles. And visceral, we all know it is mostly related to organs like heart, liver, pancreas, etc. And coming to the WHO analgesic ladder, after, the management always should be preceded by proper history taking. So you should be very clear what is the frequency of pain and what is the intensity of pain, what's the score, how the patient life is being affected with this pain, everything. So if the patient's pain score is mild, okay, suppose the patient is telling you the score between 0 to 3 or 4, okay, so what you will interpret from the score less than 4 or 3? It's mild pain, right? Yes. So for mild pain, what we usually start is non-opioid. Okay, non-opioid along with an adjuvant therapy if it is needed. Okay, plus or minus adjuvant therapy. First, we can start with a non-opioid. Okay. Then, if the management, if the pain is not in control with a non-opioid, then what we can do before proceeding to step 2 is we can add an adjuvant according to the symptoms, according to the type of pain, we can add an adjuvant along with the non-opioid in step 1. So if the pain is mild pain, first we can start a non-opioid, and we can assess the pain relief within 48 hours. And if the pain relief is not adequate, we can add some adjuvants also along with this non-opioid, and then we can again assess the pain. So that is the Step 1 of analgesic WHO analgesic ladder. Suppose the patient is not having adequate pain relief with step 1. Okay. Then what we can do is we can move on to the step 2. Or in the primary assessment, sometimes the patient may be telling the pain score between 4 to 7. Okay. Or they may not be able to tell the pain in that score. Okay, am I audible?
Yes, ma'am.
Okay.
Yes, ma'am.
Yes, okay. So if in the first stage itself, the pain score is between mild to moderate, or if it is above 3 or 4, 5, 6, 7. Okay, that means what? 4, 5, 6, 7. That means it is not mild. It is moderate, right? And the frequency also, the pain is there throughout the day. And then what we can do is we should not wait by starting the non-opioid alone. Okay. That time it is step 2. We can go directly to step 2. That means along with the non-opioid, we can add a weak opioid also in the first the first stage itself. Okay. Along with the non-opioid, we can add a weak opioid also. And we can again assess the pain relief within 48 to 72 hours. And if the pain relief is not adequate, then we can add an adjuvant. In the initial assessment itself, you will be seeing the type of pain and the main cause of pain, and also we have to correlate with that. Okay. So if there is a need of adjuvant in the first step itself, you can add that. Okay. You need not to wait for 48 to 78 hours. The step 2 means we can start it with a non-opioid along with a weak opioid. Okay. And plus or minus adjuvant therapy according to the need. Okay. Then, if the pain relief is not adequate with step 2 drugs, then the next step is to move on to the step 3. Okay. Or in the initial stage, if the patient is telling you a pain score of severe pain, like more than 8, 9, 10, or sometimes patient may be telling you the severe pain is as 10 out of 10 pain. So in those cases, you can start or you can move on to the step 3 directly. You need not to go from step 1, then wait and see, and then step 2, like that way. You can go directly to step 3 if the patient is having moderate to severe pain. Okay, I hope it's clear. In step 3, we have strong opioid along with the non-opioid. Okay, and plus or minus adjuvant therapy. Okay, one thing you have to keep in your mind is when we are moving from step 2 to step 3, if the patient is already on a weak opioid, you should stop that weak opioid before starting a strong opioid. Okay. You should not combine all these weak opioid, strong opioid, everything. So this is the WHO analgesic ladder. So now I think you all got an idea what is the WHO analgesic ladder. This is for pain management, especially for nociceptive type of pain, that is somatic and visceral pain. For neuropathic pain, we have another ladder. So you will be getting a class on neuropathic pain management. So here we will be discussing only this one. Okay. So just keep in mind, for mild pain, we have non-opioid along with adjuvant therapy. Step 2 is for mild to moderate pain. That is for that we use weak opioid plus or minus non-opioid plus or minus adjuvant therapy. It's step 3. It's moderate to severe pain, and we use strong opioid plus or minus non-opioid and plus or minus adjuvant therapy. Okay, next. And here comes the features of WHO ladder. Okay, that means most of the drug that we choose in this ladder can be given through oral route. Okay, oral route is the standard route. Okay, so if we have an option to give the medicine through oral route, then we should prefer that one only. Why? Because we know most of the palliative care patients comes under chronic cases, like it may be due to cancer or bed-bound patients or heart disease. Or it can be many other conditions like POVD, like that way, POVD, diabetic foot, it can be chronic ulcerative pancreatitis or uh, advanced cancer cases, bone pain, osteoarthritis, like this way. So all these cases cannot be managed in a hospital setting alone. They may be having pain even after they are discharged from the hospital. So we know who our patients comes under this palliative care. So most of our patients, we used to see the patients in home care, right? So we should have a medicine. We should have proper availability of medicine and for managing the pain in the home care setting itself. So if we prescribe the medicine through IV route or injections, if we prefer, what the only option is to get them back to the hospital, right? So we don't prefer that, right? What is the primary aim of palliative care? To improve the quality of life of patient, right? So I don't think they will be happy in the hospital setting. So first thing we have to do is if we can manage the condition in the home care setting, it will be good for the patient. And so if oral route is the standard route, okay, even for strong opioids like morphine, we use the oral route. And the next one, by the ladder. By the ladder means we can start from the step 1 according to the severity of pain. And if the pain is very severe, we can start the step 3 also. According to the severity, you can start. And by the clock. So, if the patient is having frequency of pain is very important, we have to assess that. And if the patient is having continuous pain, that means they need the analgesics round the clock. Okay, and we have to assess. For example, if we are starting a medicine for a pain, and if the how many hours they are getting that pain relief with that medicine, we have to assess. Okay, in the follow-up calls, in the review calls, you have to assess the duration of pain relief with that analgesics. Okay, and for example, if the patient is having pain throughout the day and you are starting the pain medication, for example, in 8-hourly dose, for example, paracetamol you are starting in 8-hourly dose and the patient is having pain relief for only 6 hours. So another 2 hours, they will be having breakthrough pain. Okay. So what you have to do is you have to increase the frequency of medicines to 6 hourly. Okay. So before before getting this breakthrough pain, before they are moving on to having this breakthrough pain, they will have adequate pain relief. And the next feature is individualized to the patient. That means the right dose is the one which relieves the pain. It will differ from one patient to the other. Okay, so titrate the dose till the pain relief is achieved, and treatment of breakthrough pain should also be specified. Okay, and use the adjuvant drugs. This adjuvant drugs we already have seen. This can be added at every step for specific type of pain and to decrease the undesirable side effects of analgesics. So, for example, if we are starting from step 1, Before going to step 2, you can just see if the pain can be managed by adding an adjuvant along with the non-opioid. Okay, like that way. And attention to detail. So you have to be very clear about the patient age, patient comorbidities they are having, drug interactions and side effect profile of the drug. Okay, next. And coming to the step 1 drugs, we know it is being used for not mild to moderate, it's used for mild pain. Okay, so we know we use non-opioid. Okay, that is NSAIDs we mostly use in the step one analgesic ladder, and it can be combined with an adjuvant drug. What is NSAID? Can anyone give an example of NSAIDs that we use for pain management?
Non-steroid anti-inflammatory.
Yeah, an example that we use commonly use.
Paracetamol. Address it.
Yeah, in our casualties or in OP basis, we used to give a brufen or diclofenac, aceclofenac. All these things we used to give, right? Toric oxide, paracetamol. Yes, next. So here we will be seeing in detail paracetamol. Okay, paracetamol, which is or acetaminophen. How it acts as paracetamol? Anyone know the mechanism of action of paracetamol? May not be knowing. I can understand. So its predominant action is it inhibits the enzyme cyclooxygenase in the central nervous system. So before this, we must know what is this cyclooxygenase enzyme and all. Do you all remember the cyclooxygenase enzyme in the cascade? There are two enzymes, cyclooxygenase COX-1 and COX-2. So I don't think everyone will be clear on cyclooxygenase enzyme. So I will be just showing that before discussing this one. So in our cell membrane, we all know we have a cell membrane, right? In our cells, cells have cell membrane. And cell membrane consists of this arachidonic acid, and through this COX-1 and COX-2 enzyme or cyclooxygenase enzyme, due to this action of this enzyme, there will be production of prostaglandins from arachidonic acid. Okay, so this COX-1 in enzyme is mainly responsible for the production of the prostaglandins, which are physiologically physiologically helpful. All prostaglandins are not harmful for the body. Okay, so this COX-1 is responsible for the production of prostaglandins, which have a protective action on gastric mucosa, this kidneys and all. So we don't prefer the inhibition of COX-1 enzyme actually. Okay, so by the action of COX-1 enzyme from arachidonic acid, the prostaglandins will be produced, and which has a protective action on our physiological system. Okay, and on the other side, the COX-2. Through the action of COX-2, that means cyclooxygenase 2, the prostaglandins that is produced is mostly mediate pain, inflammation, and fever. And that is usually inducible. This COX-2 enzyme is usually inducible. That means what? When there is a tissue injury, when there is an inflammation, okay, what happens is there will be activation of this COX-2 enzyme, that is cyclooxygenase 2 enzyme, and from arachidonic acid, this prostaglandins will be released. There are many prostaglandins PG, F2, PG, E2, PG, F2 alpha, like that way. So that mediates pain and inflammation, and that those prostaglandins are responsible for fever, like that way. So what we prefer is the inhibition of COX-2 enzyme. Okay. So this NSAIDs, there are many types of NSAIDs. There are COX-1, selective COX-1 inhibitors are there, selective COX-2 inhibitors are there. The NSAIDs that inhibit both COX-1 and COX-2, that is non-selective NSAIDs are also there. Okay, and coming to the paracetamol, that have a predominant central action. That means that inhibits the cyclooxygenase enzyme in the central nervous system. Okay, so it doesn't have an effect on peripheral cyclooxygenase. So the side effects also is very less. So antipyretic action and analgesic action, these are the primary actions of this paracetamol. So if it is, there is no anti-inflammatory action that you have to keep in mind. So if there is any anti-inflammatory or if there is any inflammation, we don't prefer what this paracetamol. What we used to give this paracetamol for fever, right? And for pain also we can give. So when we are starting this paracetamol, usually the patients and bystanders used to ask us, why it is being started? I don't have a fever or like that way. So you have to explain. This has these two actions for pain as well as for fever. You can use this paracetamol. Now it is being not started for fever. It is being started for the pain. Okay. Next, paracetamol, the safe dose is 12 to 25 milligram per kilogram. It can be given 6 hourly. The daily dose should be less than 4 milligram. And the single dose should be less than 1 gram. Okay. And there is potential. We know the most common side effects of paracetamol that we usually hear. So what is it? Liver failure, right? So even common man knows when we are starting the paracetamol in 6 hourly dose regularly, they used to ask, some of the patients used to ask us whether they can take this in this dose for a long time, like that way. So you have to tell them, even though there is a potential for hepatic toxicity, in studies it is being revealed that it is safe in liver disease in dose up to 2 to 3 gram per day. Okay, sometimes we may have to explain all these things to patient. They may be very much concerned for taking these medicines and all. And pediatric dose also you should know, it's 15 milligram per kilogram. And NNT of paracetamol is 5. NNT means number needed to treat. Okay, so when we are, if we are starting the paracetamol for 5 patients, one patient will get pain relief. Okay, that is NNT. And it can be given through oral route as well as rectal route when the oral route is not possible. IV also there is infusions also available, right? Next. And coming to non-steroid anti-inflammatory drug, we know it inhibits cyclooxygenase enzyme. It's an important enzyme in the arachidonic acid cascade, which produce tissue and inflammatory prostaglandins. So we have seen the prostaglandins, right? So that these prostaglandins are responsible for pain. What they do is this prostaglandins mediates pain through peripheral sensitization. Also, it amplifies the pain. So what this prostaglandins do is it sensitizes the nerve endings and lowers the threshold of response to pain stimuli. Okay, so also responsible for the nociceptive pain associated with inflammation. Okay, next. This we have seen. And COX-1 enzyme. Sorry. COX-1 means cyclooxygenase enzyme 1, which is present in all normal tissues, especially GI tract, platelets, kidneys, etc. It has a housekeeping enzyme. It's a housekeeping enzyme which mediates physiological response. Why? We don't prefer the inhibition of COX-1 is due to this. Okay, because it has a protective action on our stomach, kidneys, and it facilitates platelet aggregation. So what happens if it is being inhibited? The protective action on the stomach will be affected. So we will be having gastritis. Okay, or in the if it affects the platelet aggregation, what will happen? There will be bleeding risk. Okay, so that is why we used to give a proton pump inhibitor when we are starting this NSAIDs. So we know about gastric ulcer, bleed, or gastric irritation, gastritis, like that way. This is the mechanism behind it. Okay, this is the reason behind this. Maybe due to the inhibition of COX-1 enzyme. So COX-1 enzyme has a protective action on stomach, kidneys, and platelets. So we don't prefer the inhibition of COX-1 usually. Okay, this you have to keep in mind. It's a housekeeping enzyme. Then COX-2. COX-2 means cyclooxygenase 2. Cyclooxygenase, there are two types, cyclooxygenase 1 and 2. Okay. Cyclooxygenase 2 is inducible. That means when there is a tissue injury, this COX-2 gets activated. What happens is the tissue injury, inflammation, in these cases, it will produce the prostaglandins, which causes this vasodilatation, inhibition of platelet aggregation. There will be inflammation, there will be a rise in temperature, that means fever may be there. There may be pain also. Why? It will sensitize.
Huh? Why I told this, right?
It sensitizes the nerve endings. We know there are numerous nerve endings which is responsible for carrying the pain pathway, right? So this prostaglandins stimulate the nerve endings and also it amplifies the pain. So it is also responsible for this pain. Okay, it is responsible for inflammation, this pain. There may be rise in temperature, all these things. So when we inhibit the COX-2, what happens is we will get the desirable action. What is that? Pain management, anti-inflammatory action, antipyretic action. We will get it from COX-2. Okay, next. And non-selective inhibitors are also there. That is which blocks both COX-1 and COX-2. Okay, coming to the type of NSAIDs, the first one is non-selective COX inhibitors. Non-selective means it's very clear from the name itself. That means it inhibits both COX-1 and COX-2. Okay, for example, it is ibuprofen, naproxen, aspirin, piroxicam, mefenamic acid, ketorolac. We all have seen these medicines in most of the cases, right? I hope all of you know this one. So, in non-selective inhibitor, for example, brufen. So what happens is it will inhibit the COX-1 as well. So which is not preferable. That is why the patient will be having many symptoms like gastritis, gastric irritation, or if the patient is already having these symptoms, there is more risk for having gastric ulcer, like that way. And you know about mefenamic acid. For menstrual cramps and all, we prefer this mefenamic acid, right? So along with that also, we always suggested proton pump inhibitor. Otherwise, patient will be presenting with gastritis. So you have to, what you have to keep in mind is when you are prescribing or when a doctor is prescribing non-selective COX inhibitors like this, you should ask them or you should make sure that a proton pump inhibitor is being added, or what you can suggest is to ask them to take this medicine only after a proper feed, okay, to reduce the gastric irritation. Or after starting these medicines, what you have to do is you have to, obviously you have to assess the pain score and all you have to assess. Along with that, the side effects also you have to assess in the review calls and follow-up calls, like gastric irritation or any bleeding manifestations like melena. Upper GI bleed usually present as melena. Okay, so any dark RE stools or gastric abdominal discomfort if it is there. Like that way you have to assess in your follow-ups. And okay, next. So here inhibition of COX-1 derived prostanoids happens. So GI side effects like bleeding, hypersensitivity, angioedema, urticarial or bronchospasm can be there. Adverse renal effects also can also happen because it has a protective action of kidneys. And inhibition of COX-2 derived prostanoids beneficial effect. That is a beneficial effect which will have anti-inflammatory, analgesic, and antipyretic effect. Next. And side effects of non-selective NSAIDs, renal, it is 1%, that is sodium and water retention. And there is a chance for acute or chronic renal failure. So if the patient is already having renal failure, you should be very cautious when starting a non-selective. So it will have a COX-1 inhibition also. So renal protective action will be affected. So there is a chance for going the patient to ARF or acute renal failure. We know you might have seen cases with acute renal failure by taking Brufen, ketorolac, paracetamol. So what is the comorbidities the patient is having? What is the conditions they are going through? All these things you have to keep in mind. If the patient is already having gastric irritation and gastric ulcer bleed, you should be very cautious and you should tell them. Or if possible, you can choose COX-2. Okay. Gastrointestinal, that is bleeding and ulceration can happen. Hypersensitivity, that is respiratory, skin irritation, like that way. Next. And selective COX-2 inhibitors. Selective COX-2 inhibitors include, now you all know what is that COX-2 selective, what do you mean by this selective COX-2 inhibitors? The examples are celecoxib, rofecoxib, valdecoxib, toricoxib, lumaricoxib, diclofenac. This toricoxib, diclofenac and all is commonly used now also. Celecoxib also we used to use now. Next. And risk factors for GI toxicity. So what are the risk factors of COX-2 inhibitors? Okay. When it is in high advanced age, or when there is high and prolonged use of NSAIDs, or when there is a history of upper GI symptoms or bleed, or when there is concurrent use of aspirin, steroids, or anticoagulant, these are the cases which increases the risk for GI toxicity. So when a patient is already on a steroid for a long time, or that they are having some GI symptoms or use of steroids and all along with the NSAIDs, you should be cautious while starting an NSAIDs. Okay, COX-2 inhibitor. Then risk factors for renal toxicity. We know if the patient is already having a renal failure, it will be there. Age will be there, dehydration, then concurrent use of nephrotoxic drugs, beta blockers, advanced age, poorly controlled diabetes, AC inhibitors or diuretics use, creatinine clearance less than 30 ml per minute. So these are the conditions. We know most of the drugs get eliminated through our kidneys. So we should make sure that they are getting adequate amount of water. Okay, 1 second. 1 second, video. So the risk factors for renal toxicity, you should keep in mind, and risk factor for stroke or MI is more with COX-2 inhibitor. And the risk increases when there is diabetes, hypertension, hyperlipidemia, when there is a smoking habit or advanced age. So these are the things you should keep in mind. These are the comorbidities or the in history. You should assess all these things. Okay, whether this patient is having any gastric irritation or whether they are having any comorbidities like hypertension, lipidemia, whether they are having habits of smoking, or the age you have to keep in mind, whether they are on any nephrotoxic drugs, and if they are having any renal failure issues. Like that way you have to keep that in mind, and depending on that our management differs. We will be giving the analgesic NSAIDs, we will be giving, but sometimes we have to reduce the frequency of analgesics, or sometimes we have to monitor. Okay, so these things you have to keep in mind. Okay, next. So we should know whether the selective COX inhibitors are safe as compared to non-selective COX inhibitors. When we compare these two things, that is COX-2 inhibitor compared to non-selective COX inhibitors, it is safe for GAT. Okay, and renal damage, it is comparable with non-selective NSAIDs. And prothrombotic effect, that is chance for getting MI and stroke, it is more common. It's more with COX-2 inhibitors. So the patient is having hypertension, diabetes, dyslipidemia, smoking, all these things, we don't prefer COX-2 inhibitor alone. Okay, COX-2 inhibitor. Better to go with non-selective also. And selective COX-2 inhibitor were taken off from market in 2004 because of this adverse effects. Okay, so with COX-2 inhibitor like celecoxib, atorvastatin, diclofenac, etc., there is a chance for MI and stroke. So you have to keep that in mind. Okay, next. And precautions with NSAIDs. We should administer a gastroprotective drug like proton pump inhibitors. So we should monitor all these things we have already discussed. Whether there is a history of acid peptic disease or their age, the smoking habits, alcohol use, then steroid use, whether there is a history of CAD, hypertension, asthma history, renal function, gout, all these things also you have to ask in history. And avoiding bleeding tendency or with anticoagulants. Okay. So if they are, whether they are on any anticoagulants, you have to see why there will be more bleeding. Platelet aggregation, if it is affected, the bleeding may be more comparing to the patient not on this anticoagulants. And COX-2 selective inhibitors is contraindicated in atherosclerotic disease, CAD, cerebrovascular disease. So the patient is having more risk of or having diabetes, hypertension, dyslipidemia, or a history of CAD, or a history of stroke. What you have to keep in mind is thrombotic effect will be more. So COX-2 inhibitor can induce in long-term use. Okay. For 1 or 2 doses, in those things, it will not be affected. But when we are prescribing the medicine for a long term, we should be cautious. So, next. And coming to the step 2 drugs. So, we have studied step 1. Step 1 means for mild pain, we can use a non-opioid. What is a non-opioid that we use? That is NSAID. Okay. NSAID, there is 3 types mainly: selective, non-selective, then paracetamol also we have studied. Okay, next. The step 2, coming to the step 2, we usually prefer step 2 for mild to moderate pain. And step 2, we use what? Weak opioid. Okay, along with the non-opioid, we can use a weak opioid. What are all the weak opioids that you know? Some of you have answered before that use Ultracet. What's the content of Ultracet?
Tramadol and acetaminophen.
Yes. Tramadol, paracetamol, codeine. Tramadol and codeine are weak opioid.
Codeine. Yes.
Yeah. And tapentadol is also a weak opioid.
Weak opioid.
Yeah. So step 2 drugs we use weak opioid.
Dihydrocodeine also weak opioid.
Please repeat.
Which one, ma'am? Dihydrocodeine is usually weak opioid. Okay. So coming to the tramadol, it is a centrally acting drug. Okay, it's a synthetic weak opioid. It has a dual mode of action. That means it is a mu opioid receptor agonist. Okay, and it blocks presynaptic reuptake of serotonin and norepinephrine, and it inhibits the descending inhibitory pathway. Combination of tramadol and paracetamol is mainly used as step 2 drugs. And it has high oral bioavailability, so we can use, we need not to give this that as IV. Actually, we know post surgery and all we use this tramadol 100 milligram IV 8 hourly or like that way. So we can even give the medicine orally. Okay, in a home care setting also we prefer this oral route. We have seen the feature of WHO analgesic ladder. So what you should know is sometimes a patient may be coming with severe pain and they may be asking for you for injections. So that is a the psychological thing behind that. So when some patients prefer this IV route, so you should make them understand that even the oral bioavailability of this the tramadol and paracetamol is very high. So we can give the oral route, and this oral route is equally potent as what? IV route. So you should make them understand this one, and you can choose the oral route instead. So oral dose potency is 1/5 of morphine. Morphine is a strong opioid. Okay. And IV dose potency is 1/10 of morphine. This you should keep in mind. Okay. This will be helpful. Why? Because suppose the patient is on tramadol and if they are not getting adequate pain relief, you may need to convert that to morphine. In such cases, to avoid confusion, you should know. the dose potency of these medicines. So equivalent dose, IV dose potency is 1/10 of morphine. Okay. So equivalent dose is 400 milligram of tramadol will be equivalent to 40 to 80 milligram of morphine. How it comes? 1/5 and 1/10. Okay, between that one. And how we can start this tramadol? We have seen paracetamol, we can start in 500 milligram 6th hourly dose we can start, or 650 milligram 8th hourly we can start this paracetamol. Coming to the tramadol, depending upon the frequency of the pain, we can start in 50 to 100 milligram every 4 to 5 hours. And you should keep in mind maximum daily dose is 400 milligram. In paracetamol, it is 4 kilogram. Okay, so not kilogram, 4 gram. Sorry, 4 kilogram is 4,000 grams. It's not like 4 grams. Okay, so you should keep that in mind. Even in renal failure, we can use the paracetamol up to 2 to 3 gram per day. Okay, so coming to the tramadol, the maximum dose is 400 milligram. So 50 milligram 6th hourly, if we are starting, the maximum dose they are getting is 200. If they are not getting adequate pain relief with that dose, we can increase the dose to 100 milligram 6th hourly. So the maximum dose will be 400. If they are not getting relief, then we need not to wait. We can move on to the step 3. Okay. Then tapentadol also have a dual mode of action. It is also a mu receptor agonist. It inhibits pain pathways. It prevents the reuptake of serotonin and norepinephrine. And the dose is 50 to 150 milligram 6th hourly. Also up to 400 milligram. Okay. So we will be discussing step 1 and step 2 drugs today. Step 3 drugs and neuropathic pain management, you will be getting another session on that. Okay. So you have been hearing this about adjuvant drugs. In step 1, you can use. Step 2, you can use. Step 3 also, you can use this adjuvant drugs along with the non-opioid or a weak opioid or a strong opioid. So what are these adjuvant drugs means? It can be this anticonvulsant, can be antidepressant, it can be corticosteroids, bisphosphonates, cannabinoids, neuroepileptics, anesthetics agents. Also, it can all these medications can be used as an adjuvant drug. But we know the main action of these medicines or drugs is not analgesic, right? What's the action of an anticonvulsant? It's mainly used for controlling the epilepsy or seizure, right? But that have an action on neuropathic pain. Okay. So, for example, corticosteroids. The main action may not be analgesic, but it will have a supplementary action on the pain, like anti-inflammatory action this corticosteroid has, and anti-edema measure it has. So it will have a supportive action on pain management. And bisphosphonates we can use in osteoarthritis or bone meds cases also we can use bisphosphonates. Cannabinoids usually we don't use here, but for pain management, for controlling, that will have a action on the muscle spasm and all. So in some scenarios, in some regions, it can be used for muscle spasm, seizures, for pain, and also we can use this cannabinoids. Then anesthetic agents like lidocaine, lignocaine, bupivacaine, soaking, you will be learning about this in your coming sessions. Anesthetic agents means what? We know the most common anesthetic agent we use in common practice is lignocaine, right? So this lignocaine can be used for what? For bupivacaine, ropivacaine, all these things. In our setting, we use bupivacaine soft dressing for burning or what? Wound, the pain, burning pain in wound, like malignant wound or non-healing ulcer or diabetic foot. In those cases, if the patient is having the pain on the nerve endings or when they are having this pain, we used to give this bupivacaine soft dressing. Okay, so there is an action. This anesthetic agents we are using for pain management along with oral non-opioid or weak opioid. Okay, next. So this co-analgesics have multi-purpose and it can be antidepressants. We have seen antidepressants, for example, amitriptyline. Okay, amitriptyline have a analgesic action, but the main action of this antidepressant is mainly that we use in to treat in depression, right? Or any other action for amitriptyline? Amitriptyline usually we use for a neuropathic, diabetic neuropathy, and all also we used to use. So you will be getting a session on neuropathic pain. So you will be knowing more about neuropathic pain in coming session. And corticosteroids, what is the action on the pain management is if the patient is having edema. Okay, so these corticosteroids have an anti-edemal measure and it has an anti-inflammatory action, and also through these two actions it will supplement the analgesic. How? If the patient is having edema around a mass or a wound, okay, what will happen is it will compress the nerves nearby or the structures nearby. So when the edema reduces, that effect on this mass and wound get reduces. So the pain also get reduces. So that you should keep in mind, and that is itself has an anti-inflammatory action. Then sedatives. So sometimes the sleep disturbance itself can cause or itself can increase the pain. Okay, so sedative sometimes we may have to add. Antispasmodic. Sometimes the patient type of pain may be nociceptic, but there may be colicky pain or muscle spasm may be there. So that in those cases we can add some antispasmodics. And topical agents, lidocaine and all we have seen. Cannabinoids we have seen. And specific type of pain like bone pain, we can use this bisphosphonates, calcitonin, etc. You might have seen patient undergoing chemotherapy also being suggested or advised this injection of zoledronic acid, which is a bisphosphonates that will supplement the bone strength and all. So next, next one is the for musculoskeletal pain. We used to give muscle relaxants. Okay, and for bowel obstruction and all, we can use octreotide or anticholinergics and all. That will reduce the secretion and all. So these are some of the co-analgesics, or depending on the scenario, it will differ. All these things you have to keep in mind, and according to the symptom or according to the cause and the pathology, you have to add the co-analgesic. Okay. So the patient may be having mainly the nociceptic component. So along with that, they may be telling you some neuropathy component also. So you can add an antidepressant, which will have an action on neuropathic pain also. So along with the paracetamol, you can add amitriptyline if the patient is having some neuropathy component. Okay, so and the patient is having sleep disturbance along with the pain. So along with the pain management, you may have to give some sedatives also. And depending on the situation, it will differ. Okay. So this is end of today's session.
Thank you, ma'am, for the wonderful session. Anybody have any doubts on this?
No, ma'am.
Others, please respond. Yeah, ma'am. Somavelli, ma'am, do you have any questions?
Yeah, because initially I was not able to see the just wanted to see the initial slide.
Ma'am, it is not clear. Please close your microphone and talk.
Now you can hear me?
Yes, yes, you can.
Initial slides I did not see because there was problem in that. So can you just show me the initial slide to the
He's asking us to show the initial slides.
Oh, initial slides. Okay.
We will be sending you this presentation.
Yeah, you will get the PPTs.
Okay.
Yeah.
Please send that.
Do you have any? Yeah. Do you have any doubts on this? The initial slides.
Yeah, initially I was
So we have a case presentation. Before moving on to the case presentation, I would like to highlight a few things. Today we have learned many things. So especially the management of pain part 1 and part 2. So the step 1 and step 2, paracetamol, NSAID, and tramadol and adjuvants. So the adjuvants is one of the most important thing you should know what is adjuvant. So adjuvant, well, last week we learned about 2 different types of pain, nociceptive pain and neuropathic pain. So, nociceptive pain is a tissue injury. Sometimes if there is a tissue injury or that kind of pain happen, that patient like nociceptive pain. If there is any nerve injury happen or the tumor will be compressing the blood nerves, that time the patients will experiencing burning type or sharp shooting pain. That kind of pain they will report. So that is neuropathic pain. So the paracetamol and tramadol will be helpful for the nociceptive pain, not helpful. Sometimes, usually that is not helpful for the neuropathic pain. Tramadol has a component for relieving the neuropathic pain also, but if the patient is having severe neuropathic pain, then you can think about the adjuvants. What is adjuvant? Adjuvant is a drug. The primary action is not an analgesic, but it can be helpful in some painful condition. That is adjuvant. Okay. The primary action is the particular drug. Primary action is not an analgesic. For example, tricyclic antidepressants, amitriptyline and imipramine. The primary action is to reduce that is as an antidepressant drug, but it has an action on that neuropathic pain management also. So we used to use to relieve neuropathic pain patients pain also. So that is called adjuvant. Clear? So tricyclic antidepressants, corticosteroids, and anti-epileptics. These kind of things we can use for that, antispasmodics and so. So, and if the patient is not getting adequate pain relief with step 1, then you can think about step 2. That is tramadol, codeine. So the one important the precautions you have to keep it in mind is the tramadol is reduce the seizure threshold. If the patient is having a history of seizure, then you have to think about that. If you give tramadol, that will reduce the seizure threshold. Okay, so that is the one important thing you have to keep it in mind. And all other things, madam has explained very well, because the NSAID, when you prescribe, we are not an authorized person for prescribing NSAIDs, but when they come for a follow-up, you have to do the proper assessment. We all know how to assess a patient. So we should do the proper assessment whether they have a side effect before. If when a doctor is prescribed a medication for the patient, you have to give a proper explanation. Like after food, they should take NSAID. If this is one of the side, might be the patients can develop the gastritis. They should take a proton inhibitor. So that kind of things you have to tell them and ask the patient to take adequate water. So one NSAID can cause acute renal failure. That is very, very important. You have to keep it in mind. Always tell the patient to take adequate water so that all the toxic effect will excrete it out. So that is very, very important. Okay. So other all points madam has explained very well. Okay. We can move on to the case presentation. So Sandy Jungla will be presenting a case presentation today. Yeah. It's over to you. Can you able to see the slides?
Yes, ma'am.
Yeah.
Yes.
You can start.
Oh, ma'am. Hello, ma'am.
Yes.
Do I need to open the video call, video chat?
If it is possible, you can. Otherwise, also no problem.
Okay, thank you, ma'am. Hi, everyone. I'm Sandy Chungla, currently working as a staff nurse at a government hospital in Nagaland. Today, I'll be presenting on the topic Management of Pain 1. My patient is a 26-year-old female diagnosed acute myelogenous leukemia on palliative chemotherapy with type 2 SLE. Presenting complaints are fatigue, myalgia, nausea and vomiting, shortness of breath, anorexia, body ache, severe pain, abdomen. History of illness. She was hospitalized with the same complaint 1 month ago. Her hemoglobin level and platelet count were low, so she received 4 units of BRPC and then 10 units of platelets. She was diagnosed with AML and SLE on December 2023. She received 2 cycles of palliative chemotherapy till date. She had a history of abdominal discomfort after each meal and nose bleeding several times. On examination, she was conscious and oriented. Febrile, she looked pale. BP was 90/70, temperature 98, and then her saturation level was 86%, 8 room air. Treatment and significant investigation. 1 is routine investigation. HP 6 gram per DL, platelet count was 15,000, RBC 2.98, serum electrolytes, sodium 132, potassium 4.8, chloride 96. According to her ultrasound report, it shows mild ascites. Number 2 is treatment received. 1 is conservative management. 2, 3 units of PRPC, 1 unit of whole blood, 4 units of platelets, and then 3 is oxygen therapy. Psychosocial aspects. A 26-year-old unmarried woman who was a teacher working at a private school was living with her elder sister in Timapur. Her parents lives in Kohima. Last year, December, she came to visit their parents on account of Christmas holiday, but she was hospitalized. Her parents are well off. She had a younger brother and 1 elder sister. Her passion was to teach children. Now she's hospitalized and cannot move around on her own. So she's frustrated and angry at the same time. She is a devout Christian, active in every church activities, leader of her colony youth members. Now she cannot even attend the church service, which made her sad and worried. She wanted to complete her MA, but because of the illness, she can't concentrate on her studies. So the thoughts of death always haunts her. Every day she used to ask the nurses and the doctors whether she's going to die or like am I going to die soon? Her parents are more worried about her mental status that she's going through. So every night her mother used to cry. Next. The medications she's receiving now, 1 is tablet HCQ, and then tablet Ferrona XT, and tablet Corsium D, tablet ibuprofen, tablet Omnacortil 20 mg, injection Texona, injection Ceftriaxone, injection on them, Tramadol 100 mg, and then some IV fluids. Main concern is 1 is to correct the hemoglobin level and platelet counts to relieve. Second one is to relieve abdominal pain, body ache, and then the third one is to maintain her oxygen level. Summary of the patient: 26-year-old woman suffering with AML and type 2 SLE came to ER with complaint of general weakness, nausea, vomiting, abdominal pain, body ache, and is admitted in oncology ward. After she went through some blood investigation, her hemoglobin level and platelet counts were low. So she received blood transfusion and other needed intravenous and oral therapy. Discussion points. 1, what are the problems she is going through right now? 2 is, what are the key points in management of pain apart from physical therapies she's receiving? Third one is, does anxiety makes pain worse, or if, then how? Thank you.
Thank you, Cindy Jumla, for the wonderful presentation. Anybody have any more clarification regarding this patient story? I hope this presentation is clear to everyone. We can move on to the discussion points. So before that, anybody wants any clarification? Please ask. Okay, so what are, am I audible? Please respond. Am I audible?
Yes, ma'am.
Okay.
Yes, ma'am.
Yeah. Okay. Thank you. So you all go through the patient story. This is her discussion points. What are the problems she is going through right now? So we would like to hear from you all. And I have a small request to all of you because we already learned about how to do the pain assessment. if the patient is having pain, you have to take a detailed history and you have to present it in the case presentation, because we should know what is the type of pain and what is the pain score, what is the duration of pain, side issues. These all things we should know. So that is why I'm requesting you, all of you, when you submit a presentation, if the patient is having pain, please take a proper assessment. Okay. Then, so over to you all. We would like to hear from you all. So what are the problems faced by the patient? These patients, just imagine this patient and tell me your the patient's problem. And you have learned about the total pain concept also: physical, emotional, social, and spiritual pain. So share your thoughts. What all problems? Can you go back to the
nausea, vomiting,
nausea, vomiting? Okay.
pain abdomen,
Nosebleed,
Okay.
weakness, fatigue,
Okay.
abdominal pain,
Okay. Any other points?
Ma'am, I think she is on depression. So she's taking the medicines for painkiller and antibiotic and all, but she's not taking the depression medicines.
Okay. How do you say this patient is depression?
Because the patient's having the pain, she thinking about I want to die.
Okay.
She taking the medicine regularly. She's supporting the parents. She's not. Sometimes she's feeling for helplessness, hopelessness. So that's why I'm telling she's having depressions.
How many of you agree with this? So
I agree.
Rajeshwari sister was saying like this patient is having depression and you have to give an antidepressant for that. Okay. Anybody else?
Hello.
Yeah, tell me.
Ma'am, actually, we don't know whether the patient is having clinical depression or not. So just by considering her emotional status at this particular point of time, we cannot make a conclusion of depression for her. I think so.
Okay. Any other opinions? Please respond, others. So we should start adjuvant therapy like corticosteroid. For what? For what problems you would suggest corticosteroid for this patient? Who wrote that? Can you put the chat box? Kumari ma'am said we should start adjuvant therapy like corticosteroids for respiratory distress. So this patient is having respiratory distress. So you would suggest corticosteroids. Okay. Okay. Thank you for your contributions. Anyway, one more contribution: counseling needs to be given, especially regarding the illness she is going through. Very good.
So from the history, we can see she's having fatigue myalgia she is having. That means she is having body pain. She's having nausea, vomiting, shortness of breath she is having. We have seen from the history, her hemoglobin is only 6 and her oxygen saturation in the pulse oximetry is 86% in the room air. And she's anorexic and body ache is there, severe abdominal pain is there. All these are the physical symptoms, right? So all these need management. So all these are faced by her. Then, yeah, she's been diagnosed with this illness, that is cancer, and the chemotherapy is being started, right? So it is being diagnosed. She's been diagnosed on December 2023. So only few months back she's been diagnosed with such a disease. So her emotional, psychological status will also be affected. She is only 26 years of age. Okay, so we can understand, okay, how much emotional pain or psychological pain she might be having. And mostly she may be hospitalized or frequent hospital visits may be needed for chemotherapy, for management of her symptoms and all. So, and she's having abdominal discomfort after each meal. So she may be, she may not be happy to take meal also. And nose bleeding is there along with the breathlessness. She's having this nosebleed also. And investigations, yeah, hemoglobin is less, platelet count is also less. So they are giving or correcting it with platelet transfusion may be helpful for her. 4 units of platelets have been given and 3 units of PRBC have been given. 1 unit of all blood. Oxygen therapy they have started, conservative management, all these things they have started. And coming to the psychological aspects, we know the pain. We used to see the 4 aspects of pain, right? What are the 4 aspects of pain, 4 domains of pain? We assess in pain, palliative care.
PQRST.
Not that. What are the 4 domains mainly that we assess? One is physical pain, and then
Yes.
yeah, physical, social, psychological, then
Spiritual.
spiritual. Yeah, you just see the psychological aspects. She was working as a, she is not married, okay, one thing, and she might be having many dreams, okay, and she was working as a teacher in a private school, but currently she is not able to go for her job. And what her passion itself was to teach children now, but now she is mostly hospitalized and cannot move around on her own. She may need some support. She is having breathlessness. She might be having distress on walking, even on few steps. So there may be fatigue, there may be giddiness because of the slow hemoglobin and all. So she's mostly frustrated, it is already mentioned, and angry at the same time. Why? She is having all domains of pain she is having. Physical pain she is having, psychological pain she is having, social pain. What's the social component here? She cannot move around, she cannot actively participate in social gatherings, or she cannot even go to school, or she cannot even go back to her profession, right? So, and she was a devotee, and she used to go to church in every week or so, but that is also affected. She cannot even attend the church service, which made her sad and worried. That means her spiritual, there is spiritual pain also. So she wanted to complete her MA, but because of that is being affected, So all these things, and the fear of death is also there, thoughts of death, whether she will be able to cope up, or whether this disease will be cured. So all these doubts may be there in her mind. So another thing is her parents are more worried. So she may not be even able to express her pain and worries to their parents, fearing they may be, if some patients are there, they may not have a space in their home. Why? Because if they are opening up to their near ones, they will be more depressed than the patient. So what they will do is they will hold all their uh, things to themselves. So that itself will cause that frustration, and they will be expressing it as angry, uh, shouting back for silly things like that way. So if we are what if we are looking into the history, we can see there is numerous things she is going on, right? And the medications, many medications she has to take. So first point is, what are the problems she is going through right now? So all these are problems. Okay. So all these things need management also. But we know the management doesn't include the pharmacological alone. There is non-pharmacological measures also. There is psychological things you have to address, supporting measures, family counseling, the counseling for the patient, and assurance for the patient that we are still there for you, even in any stage. That itself will give some relief for the patient. Okay. So today we are discussing the pain management. So I will be concentrating more on that. And going to the next point, what are the key points in management of pain apart from physical therapies she is getting? So pain, when we are dealing with the pain management, even though we have studied the step 1 and step 2, we have seen she has been suffering from all the 4 domains of pain. So all those things need management. Okay. For example, coming to the side, social pain means she was teaching and she may not be able to go to school. Okay. For example, what we can do is we can arrange a visit for her to school. We can take her to school on one day or on some day. Or we can bring the children or the colleagues to home to see her. So, but you have to take opinion from the patient before doing all these things. Sometimes they may not be preferring others to see the patient, see them in that stage. So first thing you have to do is you have to sit with the patient and you have to explore the things. Okay. Then spiritual thing, she is not able to go to church, but you can give some what books like Bible or so you can give. In our IP wards, we used to give the devotional books like Bible, Quran, or Ramayana, like that way. Okay, so or we can play some audio or video or spiritual musics. We can devotional songs we can play. So, or we can arrange some prayer for her. So these are the things we can do. Or we can ask her itself what she would like to have. Okay, so that those things. Since the time is very less, I couldn't explain everything in detail. Then another thing is what psychological thing. She is also already worried that her parents are very much depressed, so she may not be able to express her pain to her parents. So what you do is you can arrange a one-on-two session with the patient itself, so that you can vent out her emotions fully. it may not happen in one sitting. So you can arrange multiple visits during the rounds and all, or when you are seeing the patient in home care, what you can do is you can spend more time with the patient. Okay, you can make the visit like that way. Sometimes you may have to spend even 1 hour or 2 hour with the patient. Okay, but in ward it is possible. In a home care setting, sitting with the patient for more than 1 hour may cause distress for the patient itself. So depending on the situation, you have to follow up, you have to give adequate time and space for the patient. And coming to the physical pain, what we can do is, she is already on Brufen. Okay, she is having abdominal pain, body ache, myalgia. These are the things she is having. Okay. So she is on Brufen. TDS, yes, maximum dose it is, she is on. So what we can do is, we have seen this Brufen, right? The dressing has an anti-inflammatory effect, that is an antipyretic and analgesic effect. So we have to see the pathology also. Sometimes, sorry, it has an anti-inflammatory action. It is not paracetamol. Sorry. Okay. So this Brufen has all these three actions. So it may be helpful in those ways, but her pain relief is not adequate. That is what I understood. Then tramadol it is there, but only as SOS dose. Okay. So if the pain relief is not adequate with the step 1, what we have, it is step 2. Actually, it is step 2. Why it is step 2? The patient is on a non-opioid like Brufen, and a weak opioid like tramadol is also there. It is step 2. If the pain relief is not adequate with this step 2, what we can do is increase the frequency of this medicine, or we can add some adjuvants, right? So here what we can do is, the Brufen is in optimum dose. So what we prefer is to increase the dose of tramadol. Tramadol is only giving us SOS. So we can make it as BD, or twice daily or thrice daily dose according to the frequency of the pain. We have to ask the frequency of abdominal pain. If it is continuous throughout the day, then you may have to give the medicine by the clock. We have seen the analgesic ladder salient feature, right? One of the feature is we have to give the medicine around the clock. So you have to assess the frequency of the pain. If there is pain throughout the day, then you have to give it in a round the clock manner. That means 8 hourly you can give, or 6 hourly you can give. The maximum dose is 400 milligram. That also you have to keep in mind, tramadol. And another thing is, she is having this abdominal discomfort mostly after each meal, she was telling, and this abdominal discomfort she is telling. But if you are looking into the medications list, I don't know, there is Brufen. What we have seen in Brufen, there is a chance of gastric irritation, and steroid is there, dexamethasone is there. So when a patient is having steroid, what we used to do is, when we are starting a NSAID, we used to give a proton pump inhibitor also. And on them it is ondansetron. Yeah. So we can give, or we can add some proton pump inhibitor also along with these medications. Sometimes there is a chance for gastric irritation also. So that also you can add. You can optimize the dose of tramadol, and then you can observe for another 48 hours. If the pain relief is not adequate, then definitely you can move on to the step 3. Okay, first you have to optimize the dose. In this step 2, it is only SOS dose. You can increase the dose, and there is a chance for gastric irritation. Why? Because there is NSAID, there is steroid, there is antibiotic, ceftriaxone, which is being given 12th hourly. So definitely there is a need of proton pump inhibitor that you can add, and you can increase the dose of tramadol. Coming to the pain management. Along with the physical pain, you have to deal the other pain also. I would like to mention one scenario I have heard. Uh, there is patients, and I have seen many cases. The patient may be telling pain score is 10 by 10, severe pain. They may be crying. So when we go near the patient, when we talk with the patient for some minutes or 30 minutes, or when we are giving some space, and when we are allowing them to vent out their emotion and worries, the pain score it's reduce itself without giving any medicine. Okay, you so you have to spend some time with the patient. You have to deal with the other domains of the pain, like social, spiritual, and so when they feel like they are having someone to hear them, that itself cause that itself will give some relief for the patient. Okay, so that is the second one. Then moving on to the third discussion point, that is this anxiety makes pain worse. If then how? Yes. What do you think? Yes or no?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Yeah. We know when we are anxious, we will have source of discomfort, suffocation, feeling like that way. So this anxiety, she is having the fear of death. She may not be knowing the prognosis of the disease. Okay, she she was started on palliative chemotherapy, but she might be having many doubts, like whether she will be able to go back to her work, whether this condition will worsen, or whether she will be able to live long, like that way. So those things, that means insight of the patient on diagnosis and prognosis, you have to explore. Okay, there will be some factors causing the pain. There will be something that make her anxious. So you have to explore what is causing this anxiety first. And if there is anxiety, definitely it will worsen the pain. So why? Because that may be affecting her sleep. That may be affecting her throughout the day. Okay, sir. The answer is yes. The anxiety can be presented in many ways. So we sometimes the patient may be telling you some sorts of body pain, or sometimes the patient may be telling you presenting you with sleeplessness or even breathlessness. So or abdominal discomfort. So sometimes the patient may be having nausea, vomiting. So we know before chemotherapy and all, the patient is having anxiety. Maybe she's on chemotherapy, right? Chemotherapy she was treated with the oxygen therapy and blood transfusion, everything. So there may be multiple reasons for her anxiety. So you have to know. Okay, and according to that, you have to manage.
Thank you, ma'am. I hope this discussion points are clear to everyone. I would say like if the patient is having a physical problem, there are a lot of psychosocial issues. Definitely, they have some physical problems. If they have a psychosocial distress there, the physical intensity will increase. Okay, so always try to listen their problems, explore their problems. If they are able to explore their emotions, almost we can able to they'll get a mental relief. Okay, and other than that, you have to think about the non-pharmacological management always. And if the patient is complain with any problem, you have to try to identify the underlying cause. So you have to try manage the underlying cause first. Here, this patient is having abdominal pain and ibuprofen, no that proton pump inhibitor, and also nausea, vomiting, stomach pain. So these all anorexia also. This is not able to take food also. So these all interconnected. So you have to do the proper assessment. If there is a part of these kind of things is a part of side effect of ibuprofen, you have to inform to the doctor there is no proton pump inhibitors there in the medication chart. So that is very, very important. So then we have a psychosocial issues session also. That time we will discuss more about that. Uh, time up, we can wind up today's session. Thank you.
Thank you all.
Thank you,
Thank you, ma'am.
for the wonderful presentation. Thank you, Sister Sandy Jingula, for the wonderful patient story. Thank you.
Thank you, ma'am. Thank you all.
Thank you, ma'am.